We're recording. Okay. So good morning. Thank you for watching our presentation about how to navigate the outpatient landscape when developing an emergency medicine opioid use disorder protocol. My name is Nick Rademacher. I'm an emergency physician in Grand Rapids and a consultant with the Michigan Opioid Partnership as we help emergency departments across the state develop these opioid treatment pathways. So I'm going to do a brief review of the different resources outside of your department that we'd like you to incorporate as you're developing your program. And then we're going to have the luxury of hearing from other specialists and champions across the state and across the country who have developed these programs and have insight about how to optimize all the resources available to your patients. So we're going to hear from Andy King at DMC about how they have set up a program. And then we're going to hear from Ariana Campbell from the California Bridge Project. We are going to hear from Tana Brooks from California as well about how to connect with your inpatient services. And then we're going to come back to Michigan and hear from Dominic Borgiali and Aaron McClelland about how they've done it in Genesee County. Finally, we're going to hear from Jake Mantefel in Detroit about how Henry Ford has set up their program. So at the end of today's presentation, I'm hopeful that you can take away different ideas about how to facilitate and support inpatient integration of your MOUD pathway so that when you start patients or have these conversations in the emergency department, this care can be continued when they're in the hospital. I'm going to talk about harm reduction and about some of the other community resources you may be able to utilize. I'm going to again talk about why this is a chronic medical condition and that long-term medication-based treatment is effective and life-saving, how to look for different community partners, and how to best get a plan in place with those community partners so that your patients have a place to go after you start them in the emergency department. So these projects are, kind of like onions in that there's multiple layers. You start with a desire to get people in the emergency department on life-saving medications like buprenorphine. And then I think many of us have realized that the most challenging part is making sure that you have a good outpatient community partner that you can send patients to for follow-up. And then once that's done, you realize that maybe your hospitalists or your surgeons aren't kind of knowing what you're doing. And so you need to bring them on board. And then you have patients that aren't interested in medicines. And so you need to figure out other ways to help people and utilize your harm reduction services. And then all this can be facilitated by a good peer recovery coach system. And then in your emergency department, you can use system navigators, either social workers or case managers or those that are specific to your opioid pathway. So getting a solid relationship with an outpatient team is sometimes the most challenging part of developing your ED-based pathway. And that's because there is a shortage of addiction medicine providers, in addition to a shortage of primary care physicians that have an X waiver and are willing to accept patients on buprenorphine. What makes it even more challenging is that facilities and providers advertise themselves as addiction medicine specialists or addiction service providers often don't have the same vision that we know to be evidence-based. And so this is from a phone survey a couple of years ago, but when they called around to different facilities across the country, they found that really only 30% of providers were offering medication for maintenance treatment. And we know that for buprenorphine, there really isn't a defined safe time to stop the medication. we know that at least 6 to 12 months of treatment is necessary for significant harm reduction and benefits in morbidity and mortality. But really, it's a longitudinal treatment, and there is no need to stop the medication if patients are doing well. And so, unfortunately, 30% are going to offer short-term detox, 40% aren't going to offer medications. And so you don't want to send your patients to a clinic or a provider that doesn't share the same vision for a chronic medical condition like opioid use disorder. So there's a shortage, and then on top of that, sometimes people aren't going to continue the medication. And so when you get a list of providers, it's very important as a clinical champion or your clinical pharmacist to call these patients or these providers and make sure that when you send your patients there, they're going to continue longitudinal care. How to find someone to accept your patients. There's really two main resources that we would emphasize, and that Michigan Opioid Collaborative is facilitating addiction treatment in the community and offering education to outpatient providers about how to do this. And so they have lists of people that they've trained, they have lists of providers that are willing to take patients. And so we would really suggest that you utilize their resources and to help to find someone in your community. If you have trouble with that, and certainly if you have one of our grants, please reach out to us. We're happy to help as well, but know that they're another resource you could utilize. If you're interested in kind of looking to see who has an ex-waiver in your area, SAMHSA does have a buprenorphine provider locator. I'll say that many of those listings are no longer in service, and sometimes it's pretty spotty, but it can be a way to search and see who holds an ex-waiver in your area. When you sign up for your ex-waiver, you can select to be listed in this provider locator or not. And so sometimes people just click it as they're going through the process and then actually don't end up offering these services. And so it's not completely reliable, but it can be a start at times. So the next level to this is making sure that if you start someone in the emergency department, that the inpatient services kind of know what's going on and how to continue to facilitate this treatment. And so it's very important to reach out to your hospitalist, your gynecology services, your surgical services, your anesthesiologists and psychiatrists, to let them know what's going on in the emergency department. And if they're interested, offer recommendations for what they can do to facilitate ongoing care, because we know that this isn't a short-term medical treatment. This is longitudinal. And so when they're in the hospital, this should be continued, and it does decrease the rates of leaving AMA. It improves pain control after surgery. And I think people do well with their psychiatric care when they're not in opioid withdrawal. And so kind of highlighting that there's benefit to having people on opioid agonist medication throughout their hospitalization can make the whole process better for your partners and for the patients. If you're interested in starting education or a addiction consult service in your hospital, please be aware of the HEART Initiative. This is a collaboration between Drs. Kara Poland, Dr. Trowbridge, the MHA Keystone Center, and the Community Mental Health Association of Michigan. And essentially they are working with people that apply to set up an addiction consultation services in hospitals. I recently talked to Dr. Poland, and she said if it's a smaller hospital that maybe can't support a consult service, that they can do inpatient provider education to try to make like mini consultants of the existing hospitalist team. And so it's an initiative that I think can be very helpful for a lot of hospitals that currently lack addiction medicine services. And so it's an option to reach out to. Now, sometimes our patients aren't going to be ready to, start down our medication for opioid use disorder pathway. And that's okay. People come in at different stages of readiness for change. And so I think what we need to be aware of is that there are many things we can do to make their ongoing drug use less risky, which is often termed harm reduction. And so whether that's discharging them with a Narcan kit in hand, or referring them to syringe services so that they're using clean needles, having discussions about not sharing needles, making sure that they're getting regular hepatitis and HIV testing. There's a lot that you can do for people that aren't ready to start medications to make sure that their ongoing drug use is safer. And so I would, there are, state of Michigan government resources here that you can include to make sure that they're still alive when the time comes for them to be ready to stop using drugs. One of my favorite parts of these programs are the peer recovery coaches. I was introduced to this concept when I was working in Flint, and I'm glad that Dominic and Aaron are here to share how they're doing it. But essentially, peer recovery coaches are they get a certificate through the state of Michigan. They have a history of a use disorder, in this case, typically opioid, and that they've been in recovery from that use disorder for 2 years or more. They must have experience navigating the system, which of course, I think people that have an opioid use disorder are very familiar with the system, as we can sometimes make it very challenging to navigate. And they're just great allies in this process. In Flint, they're a 24/7 service. And so anytime, day or night, you would call and someone with lived experience of using opioids would come to the bedside and talk to a patient with an opioid use disorder. I try to be as empathetic and understanding as possible, but the truth is that I just don't have the same life experience as someone who's suffered with opioid use disorder. And so, sometimes what those peers tell the patients makes them much more comfortable. They're much more willing to listen. And so many of the programs that we've helped establish throughout the state have included peer recovery coaches, and we'll hear about kind of how to include them in your program from our different speakers throughout the day. And so with that, I'm going to hand it over to Dr. King so we can hear about how he did it in the DMC.
All right, good morning, everyone. My camera's not working. It's probably because I am in I don't know, in a witness protection program, maybe. That could be it, or I could have like a blurred face. I'm not sure. But we're going to be talking about how we set this up at the Truett Medical Center here. And maybe you can learn from my mistakes or the ways that we did this. And so let's see. In general, like the idea is, can I do these back and forth? I'm sorry. The idea is that you have an emergency department where you have patients that need help, and then you want to be able to get them to ongoing care. It's a pretty simple scheme when you really think about it, right? And but there's a lot of different considerations you have to have as you're setting up these programs, and stuff that honestly maybe you didn't anticipate beforehand. But at the end of the day, it really is just like a really simple, we're going from A to B. The things that you have to decide as you're setting up these programs is what kind of ongoing care are you looking for? And there's lots of different types of care at different levels of care across the spectrum, especially if you're in a large urban area that have lots of different resources available. And so those can include an outpatient, inpatient, residential services, maybe some like stop and let's chill out kind of care, or respite care. That's another term for that I've heard recently. But that's the idea, is that you're trying to figure out where they're going to land after they go to the emergency department, because that's where all the magic happens. So when you're setting up these programs, I like to think of the audience that you're trying to sell these programs to. First of all, it's the patients, right? And patients are coming in and they're not really expecting per se, based on their previous experiences, to come to the emergency department and actually get connected to care. And so sometimes it could be a little kind of jolting for them to have someone come up and say, hey, notice that you have opioid use disorder. Would you be interested in getting some help with that? We have a place for you to go. And I've seen people shake their head in disbelief, like, what are you talking about? I don't want to go to rehab. And then there's also the practitioners that you have to, that are part of your audience too. So if you're creating a program, it should be really easy for your practitioners. It should be something that is positive experience for them, and then relatively easy for them to do or engage in, because otherwise, if you add a whole bunch more administrative tasks for them, you're going to lose people pretty quickly. When you're talking about disposition of someone with a use disorder, there's a lot of different stuff that like a social worker or someone trained in addiction care really considers, right? A lot of people have a lot of stuff and a lot of baggage with them, and they can have issues with children, comorbid mental or medical issues that they need to pay attention to, financial problems with housing and transportation. And you put all of those things together and it becomes kind of really complicated algebra, or I guess calculus maybe, or even differential equations. Like, we're getting to that point where it just becomes more and more of PTSD from college math classes, that it's really hard to figure out exactly where to put some people, because it's a lot of inputs that you're figuring out. And this is not something that most emergency clinicians are trained to do, that have a lot of experience with. And so it's really nice to have a one-stop shop, or someone that can do this for you, right? You're outsourcing a specialized knowledge base and thought process that they can take care of later, or do it for you. So the idea, again, it's very basic schema. You have patients that are coming into your emergency department, and one of the things that you could do early on is maybe send them to a respite program, because of all of those complicated things that need to be assessed for a patient. So at least you can have them go there, and you can have multiple people do an assessment for them and figure out, like, do they need to and want to go to inpatient? Are they more comfortable, or would they fit better with a residential program, or can they do an office-based treatment program? So really what you're doing is you're taking the load of making all of those complicated decisions from the emergency department, or especially clinicians that's not trained to do this, to a different program that is often separate from your hospital. So you got to get them from that hospital to that respite program, and then they can figure out the next step. And so that's one of the first things that we thought would be the easiest for both patients and providers to do, right? But it really was just setting up the process there, right? And again, this is just, the respite program is figuring all this stuff for you, so you don't have to do it. And a couple of places that we partnered with around the DMC, so next to Sinai Grace Hospital, which is in Northwest Detroit, we set up understanding with a place called Faith, Hope, and Love Outreach Center. And they have like this really comfortable area. They have back there in the door, there's a whole bunch of bunk beds. It's clean. You can watch some television if you want to. There are food and snacks. They're open 24/7. And they'll come pick you up from the emergency department. You can hang out here. And then when the social workers come in the morning, they can do that assessment and figure out exactly where you need to go afterwards, right? These are for generally medically stable patients that you're going to discharge anyway. But, they have enough going on that they can figure out, like, are you okay for outpatient therapy, which they definitely have programs too, or they can work with a social worker and then the Detroit Wayne Integrated Health Network to figure out, do they need to go to a higher level of care afterwards, because they have multiple other needs to take care of. So that's one. The other one is team wellness. A very similar idea is that they would pick them up from the emergency department, bring them there, do the assessment, do some stabilization. There are some beds there and food where they could just hang out and take a beat after their overdose, or after coming to the hospital or getting started on buprenorphine, and they can figure out what the next step is there. And so they're open 24/7, and they have the ability to just bring people in, give them a place to hang out, keep them safe, and then figure out what the next step is. And so that's the respite idea. The other thing that we had to do early on was get a pharmacy engagement. And our pharmacists are amazing. And I'm going to say that every day of the week that ends in Y, is that there was nothing easier or more pleasant to do than engage the pharmacy staff. And really it was just working with a couple of just amazing people, Casey Mangan and Rachel Wine, and asked them, hey, we want to start doing this. They were about it immediately. And so all they had to do was figure out, did some pharmacy magic for me, and then got some buprenorphine in the medication dispensation things that we have. I'm not going to use any specific brand names, but just the bupe needs to be in the emergency department, so it's easy to access, it's easy to get. The nurses can get it, or the pharmacist can dispense it, but it's got to be there so you can give it, the right medicine at the right time. And then it was provider engagement, right? And so, we have, of course, a lot of MOUD training programs that have been going on through the years that we've been a part of, and then more recently have been doing a lot of training ourselves, including this format. Some of them were reimbursed, some of them are free, some of them are asynchronous and online. And so it's just funneling providers to that. And a lot of honestly, it helped to have reimbursement for the providers to get them in the door. And then once they're in the door, they got it, like it made a lot of sense to them. But I'm not sure I could get so many people in there without some of the reimbursements that were being offered. And then residents are a little bit easier because, you have sort of a captive audience that have to do what you tell them. And some of that was easy enough to get in front of them and just do some resident training. And the thing that I've noticed too is that residents early on in training, or there's maybe just something about the new crop of medical trainees that are coming through, that they're just way more accepting of this practice. This seems just to be like a truism for them. It's like, yeah, why haven't we been doing this for decades? And we're like, exactly, why haven't we been doing this for decades? And so they're not really an audience that you have to give a lot of evidence to, because it's pretty much accepted across the board now. It's just really teaching them the how to do it, a little bit of the why, just so they can have that in the back of their minds, but it's more of the how that they're more interested in. And honestly, they're also more interested in, like, how do I talk to a patient about this stuff? And then of course there are refreshers that you can do, that you can send out little updates, little, buprenorphine factoids. I like to send out little cases that are out there. Like, I had a patient that presented with this and this happened, and so I did this, just so it's on the front of people's mind. And then early on too, we were given early feedback. And so there is a QA process that we set up with all of these, where I'd get to go through the charts and look at all the patients that were administered buprenorphine or referred to one of the outpatient providers. And I made sure that I followed back, and I sent a little happy, positive email to the whatever doctor that or clinician that sent the patient to one of our partners, and told them, hey, thanks very much for referring them. Wanted to let you know that they're doing well, and keep up the good work. And a lot of people would send me emails back like, oh, that's great. we don't get happy emails very much about patients. It's usually, hey, remember that patient that you and it's never fun, but this is an opportunity to make emergency care like a positive experience for people, where they're getting good feedback, or maybe they do want to check their emails. So again, it's real basic idea of ED to where are they going to go. And so, early on, we set up like the referral program before we had a ton of providers that were actuated or comfortable with buprenorphine. And so we kind of took that off of their plate for a bit, is that they didn't even have to initiate someone on bupe, because they would go to a center that could do it. And they didn't really have to write a prescription, because they were going to a place that was going to be taken care of, and then they would start the medications there. And so that was really nice, because it allowed some gradual training. We got to set up these programs first. We were helping patients like right away. And the providers, all they had to do was make a phone call to get it set up. And then they got some positive reinforcement for that as they were going through the process of training. So it was like a at the same time model of implementation. And now, more recently, we have recovery coaches that we're able to get into Detroit Receiving Hospital now on Adult Central campus. And so what we have is patients that are coming in, and in the emergency department, we have recovery coaches, and of course with social worker assist, helping with transportation, that they can do all of that complicated work of figuring out what the patient needs and wants and will accept. And they can make the decision about where they want to get them. Sure, they can continue to refer them to the previous partners that we talked about. They can go to a respite program, or maybe during the 4 hours of the day when they're not there and the patient can't wait till the morning when the coaches come in. that they can still get picked up and go to one of the respite programs and they can do the same thing. So both of those exist, but they a lot of times will set this up on their own, right? And they'll refer people to inpatient residential, or again, low barrier office-based treatment immediately from the ED. And they get to spend the time like sitting there, getting to know the patient, asking them like all of the other issues, and then they are trained to figure out what the best level of care for them is. And they get to do, the motivational interviewing. It's just, they bring food. I can't say enough good things about the peer recovery coaches that we have. And so, how did we get recovery coaches in? Well, we had to go through the PIHP, which is here in Detroit, is the Detroit Wayne Integrated Health Network. And we asked them, would you please help us get some recovery coaches in the ED? So you had to soften up the hospital system a little bit, say like, hey, I think this is very important. You made the case, we made the case for them, and then talked about the benefit that coaches would have coming in. You don't have to pay for them. They're going to be there. They're going to be helping patients out for lots of different reasons. It's good for the community. And there's a lot of value that they add to it. And so once they were softened up to it, then we went to Detroit Wayne Integrated Health, and then they figured out which resource that they were going to use to staff our emergency departments with. And we couldn't have been happier with the choice that was made. And so then we connected them with the executive suite. They had to hash out some legal stuff and documents and make these agreements of understanding. The contract was worked out. And then we began bringing in facilities management, so they could have a room and a phone, and they have a pager. They have access to a computer so they can look at tracking board. We involve nursing leadership, so all the nurses know that their coach is there and what they do and how they can help out. The ED leadership was more than supportive, and of course social work. And every single one of these groups of people derive different benefits from having the coaches there. And it's just a general improvement of the morale in the emergency department. The workflow has improved, and then people are just happier with how this works, right? The social workers couldn't be happier because now they don't have to do the assessment and call the 1-800 number and get people into the treatment. The nurses love it because you have an extra set of people there that can help calm people down or bring them some food or like have a discussion and engagement with them. And of course, one of our coaches brings food, and nurses love food. I think that's a truism across the board. And then the ED leadership, right? They get to see that a lot of our patients are getting good care, and then that starts translating, upstairs, and other services are jealous now. They're totally jelly of what we got going on, and they want coaches too for the entire hospital system. And so what the coaches end up doing is that they keep track of the patients that they see. They do these, they're trained on expert screening tools, and then they start tracking the referrals and the admissions. And then I'm just going to give you an idea of what our numbers look like. And this is, I can't remember how many visits we have now because of COVID's been crushing it, but somewhere between 50 and 100,000 visit ED. We had over just a couple month period of time, we had just about 400 people screened, and 270 people were referred with confirmed residential treatment admissions, right? Those are astounding numbers. And this is just the beginning of it. And they're not just hitting patients with OUD, they're hitting patients with alcohol use disorder. And you start seeing some of the patients that are coming in very frequently, coming in less frequently or not at all, because they found a place for them to go and get healthier. It's really nice to have testimonials out there too, so the coaches can talk about the different experiences that they have. And that I can use that to share with the doctors. But this is just some of the things that the nurses have said about the recovery coaches, as they help so much calming people down. They'll bring people food and listening ears. Some of the doctors say that just in general, it raises the culture and the mood of the department. They make it easier to engage patients, to soften them up. So I guess they work the body a little bit before you come in with the buprenorphine idea, because some patients can be a little bit resistant, but you have a coach in there to get it started, and they're much more accepting of care afterwards. And then one of the coaches said, man, we're doing such a good job. We're cleaning this place out. And, there's a couple of them that will go and have like little meetings with patients in the waiting room. because they'll come back in and like ask for, some advice or what have you. But it's been positive all over the place. So right now we have a recovery coach meeting so we can debrief and talk about how things are going, go over the numbers, and then address any issues that might be coming up. We give monthly feedback for providers about how they're doing. And sometimes we're tweaking a little bit. It's like, hey, you can work on your buprenorphine dosing, or like, why didn't you offer it for this person, or at least document it. And then now we also are talking about expansion. So, we got to get them in front of a couple of the other services, including OBGYN. They want to get in front of some of the residents so they can hear what it's like to go through what they've gone through in the past. And then we're looking for DMC-based referral providers. So that's it for me. I'm going to turn it over to Campbell right now, and she's got a lot of great stuff to say. So you can grab your access or control of the slides.
Thank you, Andy. So I am just going to talk a little bit more now about the California Bridge pathway. I know we've been talking in the last few sessions about what low barrier, low threshold access can look like. And a difference, when we talk about these differences in navigation, what we're trying to do in California, and our big success has been hardwiring navigation with this community of practice idea. We're getting navigators in all hospitals in California. So there's a community, and also so that they're part of the emergency department team. And we have found that that's very, very effective to get low barrier, low threshold treatment out there. And then also really engage folks in care. So let me talk a little bit about it. All right, so our goal from the start, when we started the California Bridge program, in 2018, Sarah, 2017, 2018, we knew that we needed to increase capacity to treatment. So there's a very small amount of people who had access to treatment in California, and emergency departments are very natural, likely places where folks with substance use disorders seek care for other reasons, and also where we very rapidly could give a simple medication to stabilize folks and also offer them connection to care. So that's what we set out on. And our goal was 24/7 access to high quality treatment of all substance use disorders in all California hospitals by 2025, with the idea that, let's say you cut your hand and you have a terrible laceration. You would know you can go to the emergency department and get care. We knew we needed to simplify the system so that folks could get care in their local emergency department, because we have hospitals everywhere, critical access hospitals all over. We have tiny hospitals in California with 2 beds, but we want them all to offer buprenorphine and have navigation to care. And we knew we needed an insider, somebody from the community, of the community, by the community, who could help facilitate this navigation to care. So sorry about that. So again, with universal access to addiction treatment in all hospital emergency departments, how's it going? Well, we started out in, we laid all the plans from 2017 to 2018. We started our program in June of 2018. And actually through, now we're through actually June of 2022, we have reached more than 200 hospitals, and we're aiming for 300 hospitals by the end of December 2023. So it's actually going really well. The emergency departments this is working. Giving buprenorphine in the emergency department setting is working. And this navigation, when folks say, how are you getting so many hospitals on board so quickly? We always say the secret sauce are the navigators. The navigators are driving better treatment, navigating folks to care, and also as serving as a friendly face in the emergency department, so folks feel comfortable discussing their use, discussing, things that they may not talk to me about, right? So this is the basic model. This is the model that we are facilitating the implementation of across all California hospitals. It's low barrier treatment. So we do want to treat, we do want to give medication in the emergency department. Why? Because people leave when they're not being treated with appropriate medication and when their suffering is not stabilized. So when somebody comes in withdrawal, we want to make sure we stabilize them. Otherwise, it's really rough. Could you imagine not stabilizing, stabilizing somebody's pain prior to transfer? Could you, who has a femur fracture, right? Of course, we're going to stabilize folks. So we consider giving buprenorphine for opioid withdrawal stabilization. So we are going to stabilize somebody's withdrawal, stabilize their suffering. And we do know that when we actually give the medication, we double their likelihood of being in treatment in 1 month. That's giving it in the emergency department. And our navigators are excellent advocates for patients to get evidence-based care. So this is new for a lot of us, right? I know when I first gave buprenorphine, I was a little timid. And so I didn't have a navigator standing next to me, but my navigators, all of our navigators across California have algorithms. They are able to give our docs resources so that we make sure that everybody has a shared understanding of how to do this. And they're also able sometimes to even say, okay, here's a phone number you can call if you're having, if you have some clinical questions, et cetera. And then our navigators are instrumental in all this. And I will break it down a little bit about what that can look like in a really high functioning system. But we asked our navigators to have excellent connections to community. So what I know is even in my community, there's a lot of resources. So there are a lot of programs out there. And what I found is they were well-meaning. They had great ideals. They had a lot of things to offer people, but they couldn't connect to the people who needed their services the most. So enter navigator. Folks who are really struggling, who are in our emergency department, they can help facilitate these connections to care and community. So we make sure not only are navigators making sure our patients land in clinics that are offering evidence-based treatment, and they do drive better care in the community, they're also making sure resources are available, food, housing, transportation. They're ironing out, I say, all of the problems in medicine, our navigators are ironing out, so that what we're trying to create is frictionless access to care. And the whole, that I guess at the foundation of all of that is navigation. And what this all produces is this culture of harm reduction, because our navigators are making sure that we're using appropriate language, that we are offering naloxone. In fact, naloxone in hand, my own department, 30 reversals from naloxone. My navigator is pushing naloxone access, connection to syringe services, and we actually offer syringe services through our emergency department. So driving better care for people who use drugs through this community of practice. And then what's great is our navigators support each other across the state. So for example, one of the patients that I treated was relocating to the Bay Area, which could be a state away in many places because it's a few hours away. And my navigator was able to just reach out to another navigator and make sure that this person received access to care so they didn't fall through the cracks of the system. What we do, the best definition, right? We know that we call them the SUNS, Substance Use Navigator. We've also changed their name a little bit to Bridge Navigators because our navigators are actually also now taking on a role with behavioral health. But we know the opioid epidemic takes more than one person, one profession, and that's from Carmen Navarez from the Public Health Institute. And this is something that we've been talking about for a long time. So it can't just be taken on by one person, but when we create this community of practice, people who are supporting each other, navigating for best practice, navigating to care and community, and then really advocating for best practices, we can create this wave of change that's really changing the landscape of treatment in California. So this is what it looks like when we are integrating the navigator into the ED. And again, this is important, actually. I want some differences with our navigators is they chart in the medical record. They have access to Epic or whatever system is being utilized in the hospital. They will actually chart a note like what we call a DAST or an audit. They will do screening, brief intervention, referral to treatment. Our navigators are trained in motivational interviewing. So even folks who are not there for treatment, they're able to just sit down and talk to them, see where they're at, and sometimes help move them along their journey so they're a little more, maybe considering treatment. Our clinical champions are really important, and you see a bunch of clinical champions here. We are all folks who have been driving better care, but the combination of that clinical champion with the navigator is crucial because our navigators need they need some street cred in the emergency department. They need to feel like part of the team, and then a clinical champion can integrate them into the team. So, and then what happens when the clinical champion is integrating that navigator into the team? The clinical champion is also driving better clinical care, making sure folks are all on the same page about giving the right medication at the right time, as Andy said. The navigator makes sure that that patient is guided, linked to ongoing treatment. Our navigators will even follow up with the patient, make sure they got there, sometimes even give them reminders, hey, remember your appointments at 9 o'clock today. And then what happens again is the patient gets evidence-based care, really standard practice, right? They're getting better outcomes, lower readmission rates. There was actually a study just out of Maryland that I invite you to take a look at that talked about, it's like the NavStar system, and they showed a patient savings per patient when they received navigation like this, an appropriate medication, that the cost was almost $18,000 per patient because of this navigation. So this is really important to integrate. This is what it looks like in my hospital. So this was my first navigator. I actually have a second navigator now. My navigator actually went out into my community and is trying to provide better bed space actually for folks who are needing a place to stay, because that's been a big barrier in my community. But this is the first sign that you see. You know, are you struggling with pain pills or heroin? We can help. And my navigator was able to actually get this sign up. So he was able to take care of a lot of things, iron out, again, this frictionless access and make sure that we could advertise what we were doing so folks knew. And that actually made my job easier. So when folks know that we actually provide evidence-based care, we're able to drive better treatment. People come in rather than saying they have abdominal pain or, you know, looking really sick and us not being able to figure out what's going on. They'll tell us about their substance use, and then comes in the navigator who's able to see where they're at, if they're ready for treatment, if they're even considering treatment, and even if they're not, providing harm reduction resources. And if they say, you know what, I am interested, really helping them along that journey. So staff and community involvement, you know, our navigators are role models for change in the emergency department. And we have found that they're able to reduce stigma and biases. Right now, my navigator is actually doing an anti-stigma campaign in my emergency department. And her and actually Tana, who's going to speak after me, have been doing a lot of work to reduce these stigma and biases in the hospital setting by doing a perspective taking exercise. So we recognizing my navigator is kind of the boots on the ground, able to know what's going on when I'm not there. And she's able, you know, we identified that stigma was a problem across the board that was creating barriers for our patients. So we're actually doing evidence-based interventions to reduce that. And then what our navigator can do is provide support to the ED team. Frequently, when I go to see a patient, they've already been seen by my navigator. She's already identified if they're in enough withdrawal for medication. And then she's able to say, hey, you know what, they're really sick, they really need medication, and advocate for that patient to get evidence-based care. And then we always do, we do frequent check-ins, make sure everything's going okay. When we have resistance to treatment, when we have resistance to the program, we're able to work together and talk about it and figure out how we can provide better care. And then again, my navigator is working with these community resources. We're actually trying to get OD maps on board. We've identified different gaps in our system of care in our community because my navigator really she has an ear on the ground, what's going on, and we can figure out how we can provide better care for folks. And in the end, what we are doing is building these trusting relationships with patients and families so that they know that their family member, their loved one, or them are going to get great care in our emergency department. So I broke this down. We'll send these slides out, but I'm not going to go through every detail here, but I just want to make the point, and I'm going to go through this a little bit more, is that folks can get care from our navigator at every point on the spectrum. So even before they come into the emergency department, my navigator's phone number is distributed widely. And if she's not there, then sometimes we put it into discharge instructions to reach out. Sometimes we send a note to her and say, hey, I think this person would benefit from a talk with you. You know, like maybe you can reach out. I ask my patients, if my navigator's not there, I'll say, hey, is it okay if my navigator reaches out to you to see what we can do to help you more? And so again, even before somebody's visit, some people will call her and talk to her about their struggles. She'll sometimes even meet them in the lobby. We make sure that our greeters are, for us, it's registration, know about our program, so know that not to discourage treatment. And then again, my navigator can be involved in the treatment area. Sometimes she sees that people need help and she'll just pop into their room. And then even after the folks are discharged, she's able to provide care to people and does some follow-up, make sure they make appointments. We've actually found that a 30-day follow-up phone call can be really meaningful, because that may be a time when people are struggling a little bit more. And sometimes just a call from my navigator can make a big difference. So again, pre-visit, what are examples of how a navigator who's integrated in the ED works for the hospital, right? How can they make a difference pre-visit? She's made sure that her contact information is available out in our community. So in my community, we don't have any sobering centers or detox facilities, but she just makes sure that even the clinics know that she can be contacted. Community clinics know the availability of navigators. And again, we make sure that everybody has access. So we, it's important to get her information out there so folks know, if they're just kind of contemplative but not sure, will they really help me, that they can call her. And then this is actually really important. A lot of folks come into the emergency department and then get a little, they might get a little intimidated. My lobby doesn't always look great, right? Sometimes there's a lot of people waiting because it's a super busy day. She's able to really get into, one of the last patients I treated, when I went out to see them, because we didn't have any beds, I just wanted to see where they were at, see if we can treat them even from the lobby. She was actually able to sit with them while they were contemplating leaving, really encourage them to stay. And she did a brief assessment and just made my job really easy. And then, even making sure that if somebody comes in, like in triage, so actually we made the ability to refer to the navigator easy, even from triage. My triage nurse can put in an order for the navigator, so we can engage really quickly. So she's able to even get some word out for just from triage. And then in the treatment area, making sure my navigator has access to our board, make sure that she has access to our electronic board, and make sure that she can see, maybe there's people that we forgot, people we didn't identify because we're super busy. Sometimes I'll say, oh, I forgot to call you. And she'll say, oh, I already went to see them. I saw them on the board. That's really important that she has access to that. And then, of course, at discharge, this is very important. We've talked about this. This is what the whole name of the game is making sure that folks have frictionless access to ongoing treatment, and making sure they have, they know that we care, we can provide some navigation and also some follow-up. So, and making sure they have harm reduction resources. So what does it look like when this is a successful program? It's an authentic patient connection. So making sure folks know that we care and we're there for them, and that we're also able to provide evidence-based treatment, because there's stigma within the community of people who use drugs. Why? Well, historically, medicine has not necessarily treated them well. So they don't necessarily trust that we're going to do that this time. But our navigator is able to establish these authentic patient connections. We're able to rapidly start medication. And then there's a very simple process for filling a prescription. Why? Because if there are barriers, the patient has my navigator's phone number. She'll iron things out if there's a problem at the pharmacy, and we all know there's historically problems at the pharmacy, and sometimes needs to get one of the prescribers involved to make a phone call. But I always say that the best, what we're going for is a patient gets frictionless treatment. They can come in, get evidence-based treatment, stabilized, access to follow-up care, whatever resources they need for harm reduction. They can go to the pharmacy, actually pick up the prescription, be able to take their medication, be able to go to an appointment without so many barriers. And when I say this out loud, you think, shouldn't that just happen already? Well, unfortunately, there's so many barriers, so much red tape out there already, that the navigators are necessary to make it frictionless. And then we have this warm handoff to a referral facility. And if anything goes wrong, we have a point of contact. And then again, in all phases of treatment, we make sure that this is patient-centered. So what happens when we have a successful system is there's this reassurance of safety. Folks can disclose to us that they have a substance use disorder, or that they're struggling with a substance, and they receive non-stigmatized medical care. And follow-up, check in with patients within a week, a few weeks later, makes all the difference in the world, so that folks know that we're there for them, and we know that it can be difficult, but we're going to help iron things out, even if they happen, a month down the road, right? Let's see if this video will play. Are you able to play? I don't see it play. Well, I have a great video in this slide deck. We'll send the slide deck to you. And this is a video that can be shared about what a navigator's role can be and what it can look like in a successful system. This is a picture, probably not her favorite one of Reb Close, from one of our partners she works at the Community Hospital of Monterey Peninsula. And she is driving a really great program. And this is a great video about her program. All right. Okay, so what's the impact been? Well, and I attribute this to our navigators. We knew we needed insiders. We needed insiders in all the hospitals in California. So this is 196 hospitals reporting through May of 2022. So we're getting data from 196 hospitals. That's a win in and of itself, right? But through those 196 hospitals, some of them fairly new. We started with 52 hospitals in 2018. So many of these hospitals just started their programs. But over this period of time, from April 2019 through May of 2022, this is what we were able to do in about a 3-year period of time. More than 162,000 folks were seen for substance use disorders by our navigators. More than 117, almost 118,000 folks were identified with opioid use disorders in California hospitals, and more than 54,000 folks were provided with buprenorphine. That's what it can look like when you have navigators who are driving better care in emergency departments, making it safe for folks to disclose their use disorder and making it safe for prescribers, for clinicians to treat with evidence-based care. We have lots of resources. I always offer these up. Here's the QR code. We all are used to QR codes now, but we have a lot of resources. I know we've shared some in the chat. Sometimes I think the most commonly thing people ask for once we've described this position is, what's your job description? We have a job description available. We can put it in the chat as well. And I just want to emphasize with our navigators, there's no degree required. We wanted to make sure our navigators were people who care deeply about people who use drugs, that were from the community. And our navigators, we do favor folks who have lived history, but it's not required. So our navigators are anybody from folks with lived history to people who have maybe some family members who have struggled, to people who just have this passion to help people who use drugs. And again, I think some of the magic was in that job description of making sure that we were pairing the right people in the emergency department setting to make sure that they provide this navigation. So I welcome you to take a look at some of those resources, including our navigation toolkit and how we built our program. All right, I'm going to turn this over to Tana, who's done quite a bit of work from my hospital on the nursing side, and she's driving better care for nurses across California. And I'm just really excited to have her here to talk to you a little bit about how nurses can get involved, advocate for patients along the spectrum in the hospital setting.
And before we have Tana go, do you mind talking for just a minute about like funding? How do you guys pay for coaches and substance use navigators?
Oh yeah, of course. So we started out by providing funding for navigators because we call them startup funds. So we knew that we're introducing a new job. We're asking that it is in the emergency department hospital setting. So we applied for grants through the state opioid response. So the first state SOR grant, California Bridge applied for money to give to hospitals. So we gave about $150,000 to each hospital that first applied in California. And that was 52 hospitals. And that went to pay for navigators and for champions, as well as some IT support, et cetera. So those were initial grants to the hospitals, not a huge amount, but enough that we kind of had this magic spot that they were able to hire navigators with that money. We were able to continue navigators for another couple of years after that because actually Cal ACEP, our California ACEP group, found great value in this. So they lobbied for our state to provide funding. So the second round, our state did a line item in the state budget to provide $100,000 to each hospital. And that was for 200 hospitals in California. That's how we got to that 196 number. So we gave 200 hospitals $100,000 each to support the navigator. This is all startup funds, right? Because this is a new position. The California Hospital Association found that this was very valuable and that hospitals found great value to this. We reduce readmissions, we reduce length of stay in the ED. Hospital partners really liked this. So they also advocated at the state level and were able to help us get through another line item in the budget. This time it's $120,000. We landed at the sweet spot for every hospital in California, 300 hospitals. So this is being utilized to continue the navigation, but we're not going to have this. This is not in perpetuity. What's happened on the back end is the state, the Department of Healthcare Services, has advocated for Medicaid channels to reimburse navigation services through community health worker funds. This is brand new. Community health worker funds are brand new, and we are looking at this right now and piloting community health worker reimbursement at hospitals. Some of our hospitals are continuing navigation, and they've actually said so at my hospital, we don't bill for our navigation services, but our navigator is now hardwired into our emergency department budget because we found that this one position in our emergency department, and I'm not a huge emergency department, but this one position has created a lot of cost savings. It's created better. My nurses don't have to spend as much time bedside with certain patients who may require a little bit more. My navigator is able to spend a lot of time with folks with complex care issues. And so we found that it was extremely valuable. So they're just part of our budget, but we're looking at this community health worker funding, which is available in every state, and seeing how we can apply it in California to fund this. There's also ability to bill for some expert services. So some folks are doing that, but we just found that it's incredibly valuable, and now it's part of our emergency department budget. Many hospitals are doing that. So that, just to answer your question, we started out with grant funding, but we're continuing it because it's proven itself to be incredibly worthy. And as I said, I think it was a Maryland study, I think it was University of Maryland, found that the cost savings per patient for navigators was almost $18,000.
Awesome, thank you.
All right. Hello. Thank you for having me. My name is Tana Brooks, and it's an honor to be with you today. I have the pleasure of practicing as a charge nurse in an emergency department, actually with Ariana. And then I also get to work with our California Bridge team as a nurse advisor. So I help to support nurses and advocate for best practice treatment in all our California hospitals. I first got involved in this work when I got to experience firsthand, like at the bedside, how incredibly powerful and life-saving it really is to provide our patients with the right treatment at the right time. We're trying to go next slide here. There we go. So first and foremost, it really does take a whole team to provide best practice care. This is true for all of our chronic diseases, right? It takes a team. And what's different about substance use disorder is that they're so stigmatized that our patients often choose not to disclose their drug use, or they don't even come for care, or they only share it with a trusted provider, which is why we really need our whole team to understand how to treat it and why we're treating it that way. The team member I want to highlight for just a quick moment is our navigators. Ariana already talked about that in depth, but they are so important to our team, and they are just invaluable. It's that person who can come and connect with our patient, help them navigate the system so that they have a solid plan in place. What I want to advocate for is navigator consults early and often. That's what we're doing at our facility, and it makes a huge difference to get them involved early. Throughout their inpatient stay, we are always looking at our ultimate disposition and discharge plan for our patients. And so our patients with substance use disorders are the same. How can we meet this patient and set them up for success when they leave here? And it takes our whole team advocating for that and thinking through that plan, because it can be a little bit complicated sometimes. So we're talking about having an empowered team that advocates for best practice care, and an essential aspect to building this team is really sharing the most up-to-date practice. Our team needs to know that information in order to advocate for it. I think sometimes as nurses, we get like new protocols, new this, new that, and we really want to know the why. Like, nurses need to understand that why in order to advocate for it. All right, there's a few key pieces of information that I think are super important for our teams to know, and I want to encourage you to share this with your teams as you're, interacting with them, talking with them. It can be just casual, but share this information with your team so that they can advocate for what care their patients need. So first and foremost, addiction is not a moral failing. It's a chronic disease that requires medical care. So I like to equate it to type 2 diabetes or hypertension. If a patient shows up in our hospital because they didn't follow their treatment plan for that chronic disease and they're now in crisis, what do? We treat them, right? And it's the exact same for our patients with substance use disorders. Next, I want to highlight how important it is to use words that recognize the person first. And so our words matter, right? This is so important. How we speak to our patients, to the patient, and also to our teams actually affects how we think about them and how we treat them and interact with them. So if we utilize discriminatory language or stigmatized language, we actually create barriers to care. And in addition, the language we use affects not only how the patient perceives us and feels about their care, but it impacts how our team approaches them. So some of the terms that I want to highlight that we should use are just putting that word person first, right? So person with a substance use disorder, person with an alcohol use disorder. And then we want to avoid those really stigmatizing terms like addict, abuser, junkie, alcoholic, things like that. And if we model that to our teams, it will really help. All right, I love this information and I share it with my nursing teams all the time. And so it just really highlights how effective the treatment we have is for treating substance use disorders. So when we give an aspirin for a patient experiencing a STEMI, it takes 42 patients that we treat to make an impact on one life. Warfarin and AFib, it takes 25 that we treat to prevent a stroke. And then when you look at buprenorphine for opioid use disorder, it only takes 2 that we treat to retain 1 in treatment. This is incredibly effective and it's very safe. So share that with your teams. It is incredible when I share this with my nurses. It makes the biggest difference in them taking the minute to advocate for this treatment if they have a patient who discloses that they have opioid use. Piggybacking on that, I wanted to highlight a study that was done, and it looked at follow-up rates for opioid-dependent patients who were seen in the emergency department, but I think this translates pretty well to the inpatient setting as well. So they looked at 3 groups of patients. The first group was screened and referred to treatment. The second group was screened, had a brief intervention, and was referred to community-based treatment services. And then the last group was screened, had a brief intervention, and was actually started on medication in the emergency department, and then referred to primary care for a follow-up. So at 30 days, what they saw is the group that was provided medication in the emergency department had 78% follow-up rate at 30 days. And the group that was just screened and referred to treatment had a 37% follow-up rate. So I think this is like having that information to share with your teams can really help us advocate for the best practice treatment for our patients. So even on the inpatient side, if a patient starts experiencing opioid withdrawal, we want our team, our nurses, our physicians, everybody involved in their care to know that there's medication that's effective that really makes a difference for our patients. All right, and handoff is key. This is true for nurses handing off patients, physicians handing off patients, any type of provider for, having a handoff of their patient to another care area. This is when we lose information. So, and this can contribute to our adverse events and patient safety risks. And I think that this definitely impacts our patients with substance use disorders. They might have shared with one provider that they use opioids, but they're probably not going to share it with each person on the team that interacts with them subsequently. And so we need to make sure that we're thinking through what is super important to information to provide at handoff so that we make sure we don't miss these things. All right, and lastly, what does success look like? It really looks like a hospital that understands. So using those words that are not stigmatizing, that recognize that a person is a person first and behavior is something that can be changed. And then it looks like a team that treats with dignity and respect. And lastly, our patients' goals are met. Thank you so much.
And next up, we have Dominic Borgiali and Aaron McClelland from Genesee County.
So many buttons. Okay. Good morning-ish, 11 o'clock. So as you can see, Dr. Borgiali is not on with us yet, but hopefully he'll be on with us soon. So I am going to do my best to go through this presentation to share with you the Genesee County method, how we were addressing the opioid epidemic here in our area beginning in 2018. So hopefully I did this screen sharing correctly. You said to use the arrows. Am I shared screen? So, oh, here's the arrows down here. Okay, that's the last page. No, that's yours. Okay, so yes, here's our first slide. That's just how we contact the ORP program. So if you continuously hear me using that acronym, it does stand for the Opioid Overdose Recovery Program. And I will share towards the end about the funding, but we started this program in 2018, about halfway through the year 2018. There was another program that actually had this grant through our region PIHP here, Region 10. And knowing that New Pass itself already had a working relationship with the 3 area hospitals in Genesee County, the PIHP approached us and asked us if we would be interested in providing peer recovery coach services in the hospital. We have a sobering facility here at New Pass that the hospitals have used for the last 10 years. It's not a detox. However, it is a safe place for people who are under the influence or seeking services where they can go without utilizing an emergency room setting. So hospitals were very familiar with New Pass in that sense. So that's why we were awarded the grant for the rest of 2018 and continues today. So when we were starting our ORP program, our first orders of business were to establish business agreements. We had to establish our protocols for opioid overdose recovery program because we had to make sure that we were following all the protocols involved with our organization. And then of course, meeting the hospitals where they're at and making sure that everyone understood their role and what that was going to look like with us going into the hospitals. So we quickly established those. And then we also had to make sure all of our staff were appropriately trained. And we have state certified recovery coaches. We have CCAR certified coaches who specifically went through a training called working in the emergency department. So they would understand their roles because in no way, shape, or form are they medical directors or able to make medical diagnoses or medical decisions. They are strictly that person in lived recovery, meeting that individual where they are at, and being able to access and navigate through systems. They've also been trained in ethics and professionalism. Our current ORP coaches are trained in naloxone and are now, 2 of our coaches are trained the trainers for naloxone administration. And they've also been trained in harm reduction models, as been, that was shared in other slides, that it isn't just a one-stop shop for treatment modalities, that many of our clients are not ready in that moment. So we do provide them with naloxone. We also provide them with fentanyl testing strips. And then any other, access to needle exchange programs and anything else that they may need along their journey. So in the 3 emergency departments here in Genesee County, which is Hurley, Ascension, Genesis, and McLaren. The first step, of course, is for the emergency department to make sure patients are stabilized. That was one of the protocols we had to put in place. Somebody who's unconscious or in a state where they cannot communicate back with their coaches is not ideal for an ORP coach to see that person at that time. So the emergency department does a really nice job of making sure they contact us once a person is stable. And obviously before discharge, plans are discussed. We talk about the emergency department staff also talks about identifying needs, their interest in treatment. And at that point, if they are interested in treatment, they do contact our coaches, which Dr. Rademacher shared earlier, that our coaches are on call 24 hours a day, 7 days a week, 365 days a year. They do get days off through rotation, but other than that, they are on call just like physicians are. So they kind of feel cool about that. Now they might feel a little tired, but I think they really enjoy that actually. So they can get calls at any time of the day. And initially, this program was identified for opioid use disorder, but as the calls were coming in from the hospitals, it was identified that there was a need for other substances as well. And a lot of the individuals who were overdosing would completely deny that opioids were a drug of choice for them. They would say it's cocaine or it's meth or even marijuana, but there were opioids, fentanyl specifically in their substances that they were using. So just informing them and educating them about the substances that are out here that are very risky for them. So obviously through the pandemic, we did see an increase in alcohol use due to accessibility. So a lot of our calls now are still primary opioid use, but also a very high percentage of the calls we receive now are for alcohol use disorder. And NewPass, that is actually the organization that I work for and where our coaches are established. However, we are not the only provider that our ORP program utilizes. So they're sort of separate, although they are our employees. It isn't, oh, we only feed the NewPass program, which is a large treatment center here in Genesee County. We partner with all of the treatment centers. We partner with all of the MAT programs, harm reduction programs, community mental health programs, physical health programs. So it's where that person is. So what NewPass is we're a nonprofit agency here in Flint, Michigan, and we serve over 4,200 people annually. And some of those individuals come voluntarily, and we do also have court-referred programs or court-motivated programs as well, where individuals can access services here or be referred through the courts as a diversion to jail. They were established in 1979 as an alternative to jail program. And since then, I'd say over the last 10 years is where we really revolved into a really large treatment center, primarily Medicaid patients. However, we're currently being paneled with private and commercial insurance base. So that way we don't have any barriers or gaps for people seeking services. We provide all levels of care except for detox. However, with working with the hospitals, we've been very fortunate that if somebody is in need of an MAT or comfort medications while they come to our sobering facility before they can get into a detox or residential program, because it's not always same day access, that our hospitals have worked with our peer recovery coaches to assist those individuals. So they're not just put back on the street or at risk of overdosing again. And we really just try to help them, meet them where they're at and get them into those services where it's needed. And with all of this starting and all of the partners that we've established through this process, we're actually able to open our own MAT clinic in September of 2022, which is just a few weeks away. So we're very excited to do that. And really where this came from was there's obviously barriers and gaps in our community with accessibility to MAT treatment. The hospitals really took a huge responsibility by starting MAT in the emergency departments. Hurley and Ascension Genesis were the two big champions with that because of the people continuously coming into the emergency department. And some would say, I've been on MAT, or if I just had an MAT program, I think I could start working on my recovery or, my sobriety. And, one of those key factors is they do have to be linked with one of our peer recovery coaches. So the doctors, the physicians in the emergency department would do that warm handoff. They would be able to prescribe the medication and then, like I said, provide that warm handoff to our coaches. I believe that the physicians started to see more and more individuals who needed to start those programs and not enough MAT providers in our area. There's usually a 2-week wait list for somebody to start Suboxone in our area. Our methadone clinics have been full. Part of that is staffing issues as well, just not enough clinicians to see all the individuals who need these services. And, we went to our partners and our partners came to us and said, will NewPass do this. And so we have been working on protocols and process for about the last 4 months, and September 6th is our launch date. So we're already getting calls from some of the physicians. Erin, have you opened your program yet? Have you opened your program yet? I said, it's so close. It's so close. Don't bombard us all at once because we still have a staffing shortage here too, but it'll be great. And then I know that the doctors and the physicians and the social workers and the ED take these opportunities for training and learning within their own programs. When we initially presented this program to the hospitals, you could just see the burnout and the fatigue on many of the staff who work in the ED, because they were, constantly seeing these same individuals coming in and out. We know how this disease works. And you can say it's only addiction, but I got to imagine you see people in the ED as well with other health issues and medical issues, not just addiction, but for some reason, as we all know, that stigma, those stereotypes that come out like, oh, this person just doesn't want help. They just keep showing back up here. And we would hear horror stories, but I know some of it is true and some of it isn't. I mean, we get burned out as clinicians as well too. And we just really wanted to provide this extra level of support to the hospital staff. And I believe bringing in the peer recovery coaches brought hope to their team as well, because people can recover and people do recover. And now here they are giving back that was given to them. And so our team built wonderful relationships with the physicians and nurses and the social workers, able to share their stories. And it's like, wow, this is great. People can get help, people can do better, you can turn your lives around. And we just saw just a huge uplifting, I would say, from talking to social workers and physicians, just their whole attitude starting to change towards addiction. And it takes time, but it has been positive. So this would probably be more where Dr. Borjali steps in, but I do know these processes as well. So the emergency department identifies a patient who displays problematic drug, substance, and chemical dependency behavior patterns. The emergency department approaches that patient and presents them with an opportunity to receive ORP services in preparation for the facility's discharge process. Oop, did I hit another slide? I did. Okay. So at that time, they do, Hurley and Ascension both do a wonderful job of asking the patient, is this something they would like to do? Sometimes Hurley may just call us and say, we have somebody on the way. And with some of our other partnerships we've developed with EMS and the Sheriff's Department, sometimes they call us now when they're on their way to Hurley or another hospital with a patient. So oftentimes we might be there before the patient even arrives due to, our partnerships with EMS now. However, they do talk to the patient, they respect their wishes as well and their requests. And if that patient agrees to receive ORP services, that emergency department staff calls the ORP 24/7 on-call coach. And it is the coach's responsibility to show up at that hospital within 30 minutes. Which we were challenged on that in the beginning, and we made it. And I think our average response time is 22 minutes to the hospitals. So yes, our coaches arrive, they meet with the social worker or the physician and find out where the patient is. And it isn't just the emergency room. We can and have gone to other areas of the hospital if there's a need. We do know sometimes individuals who come in with substance use issues also have other health issues where they may get transported admitted into the hospital and transported to a different floor. So our pre-recovery coaches are available to them as well in those other areas of the hospital. If there was a need, we can also provide services by phone or video conference, which was utilized at times during COVID. Obviously, everyone was under strict guidelines, but overdoses didn't stop and substance use disorder did not stop during a pandemic. So we found ways to make it work. And I would say we maintained, being successful and making sure people had those services available to them during that critical time. Post initial patient contact, that ORP peer recovery coach talks to the medical professional and discusses next steps. Whether that patient may come over to our sobering facility, If it's during, hours where we can access them to an inpatient facility, we'll do that. Sometimes it's just outpatient services, which is completely acceptable as well. Sometimes it's just going to remain peer recovery coach services. So with our grant, we are able to stay in contact with our clients for 90 days. And just because there's a 90-day number doesn't mean that the individuals don't still have our ORP phone numbers and don't still call our coaches after those 90 days. That's just what the grant says. So the role of our peer recovery coach sounds very similar to the models that have been shared today. But I'll just share, our job descriptions and what's, expected of our peer recovery coaches. So they are a person in long-term recovery with lived experience in active addiction. A peer recovery coach takes a non-clinical and non-medical approach to combating addiction, but has undergone the required trainings to become certified to act as a peer, family, and professional support to help connect substance use disorder patients to treatment and improve treatment outcomes. A peer recovery coach advocates, motivates, and coordinates by working to tear down stigmas, barriers, and obstacles for people afflicted with the disease of addiction. A peer recovery coach supports individuals in present crisis and helps them to identify and discover their own pathway to recovery with continued contact for 90 days as a client. A peer recovery coach can be viewed as a vehicle that helps drive the individual from the emergency department or medical facility to their treatment pathway and into long-term sustainable recovery. And we, in addition, similar to the navigator piece that was talked about earlier, we also have a care coordinator, and I guess our old term would have been case manager. Names evolve, titles evolve, but we also are able to staff care coordinators in this program. And so that peer coach is right in the, they're in the root of everything. They're doing that initial contact. They're there in that crisis situation. We get that individual stabilized, and within 24 to 48 hours, our care coordinator team is picking up where that peer recovery coach left off in regards to accessing services. Sometimes our care coordinators have a little bit more time because our ORP coaches are always on call to help navigate, make referrals, whether that's to medical, physical health, mental health, spiritual health, daycare, things of getting their bills taken care of. We even had somebody who needed their, like a foster dog family so that they could go into treatment. We did find a foster dog family who could take their dog, but the person did decline treatment and decided to try outpatient. I totally understand. I don't know if I could just leave my dog with somebody while I was in treatment. That might create some additional anxiety for me. I'm not sure. But we do help link them to any type of need that they have, clothing, food, whatever those services are. That's where that care coordinator steps in. And one of our partners in this who funds us is the Greater Flint Health Coalition, and they have a program called CHAP, and they have a social worker on hand who helps link our team to those resources. So our resources and partners just expand and expand and expand. It's amazing what we look like right now. And they're able to access them to anything. If we are experiencing barriers, for some reason, CHAP has a magic wand and can make things happen sometimes if we can't. So it's been a really great resource to have, and it truly is a team, and they work as a team. We have an amazing team here. So I just wanted to share some of our outcomes as we started this program. And data tracking is always a challenge because you're just not really sure what it is you have to track sometimes. And when you have multiple funding sources coming in, this funding source wants you to track this funding source wants you to track that. One funding source didn't even tell us we had to track anything until about 6 months into the program. And we were like, oh, we need to develop a tracking system here. So in 2018, that's kind of what happened, since we did start halfway through the year of 2018. So that was where we worked on establishing protocols, creating a data tracking program, building partnerships, going out and meeting with hospital staff, medical professionals, and social workers. This is where we were really selling our product, which didn't take too long to sell. They're basically like, when can you get here? In 2019, we had 559 referrals, and it breaks it down from the hospitals there. This was like the out the gate, the horse is going. they were, everything was going great. Obviously, we know what happens in 2020. So here's our pretty picture of 19. Of those 559 referrals, 96 refused treatment, like declined it at that time. It doesn't mean that those 96 didn't surface at another time and accepted care. I didn't quite have that breakdown available, but it does show that we had an 83% engagement rate from the hospital staff to our clients in ORP, which was a great number to me, because most of us who work in SUD treatment know that if we get a 50% rate of success, that's good. And sometimes we're sad about that. So an 83% engagement rate is very positive. For the opioid primary referrals, you can see that broke down from Hurley Hospital at 163, Ascension, Genesis 14, and McLaren 19. We linked 334 of those individuals just engaged in peer recovery coach services. In addition to that, 334 people, other individuals engaged in other levels of service such as detox, residential, and outpatient services. In 2020, I don't even like saying that year, but we have to. So we had 447 referrals, and 390 of those came from Hurley, 29 from Ascension, and McLaren 28. And Dr. Bojali, I see he's on here now, and Dr. Rademacher can talk more about why Hurley numbers are higher. They are our community hospital. If anybody goes to a hospital, it's usually Hurley. And if anybody's in distress or a crisis, they go to Hurley. So I'm sure Doctor will touch on that here in just a minute. That year we had 54 refusals. So we had an 88% engagement rate, which is excellent. You can see from the opioids, we had 110 from Hurley, Ascension 12, McLaren 18. You can see how many still stayed in contact with our peer recovery coach services. That was 329, and 70 additional went into other treatment services such as detox, residential, and outpatient. 2021, we were continuously experiencing the residual effects of the COVID-19 pandemic. One thing that I don't have in here that I'd love to share if I have another opportunity is our sobering house referrals. A sobering facility is funded through our Public Act dollars and block grant dollars. So it's not an insurance-based program. And during the pandemic, many people found that as a safe place to go. We kind of know that going to the hospital was more serious, more of the serious COVID type situation. So many people avoided going to hospitals. However, our sobering facility stayed open. We did not close. We never stopped services. So many people came in during that time. And I should have pulled that data. And now that I'm sitting here thinking about it, that would have been a good idea. So we still contacted the hospitals though. There was still a need to coordinate with our medical professionals because like I said, we are not medical professionals. But we still ended up having 377 referrals in 2021, and 311 came from Hurley, 42 from Ascension, and 24 from McLaren. We had an 88% engagement rate with only 44 refusals. And you can see where the opioid numbers were again with Hurley with 88, Ascension 12, and McLaren 15. 300 engaged in peer recovery coach services, and another 33 engaged in other treatment services. And this is when we had to start, it was probably towards the middle, the end of 2021, began tracking MOUD in the hospitals. So if the hospitals were going to start a person on an MAT protocol and refer them to our ORP program, this is when that started in that year. And we had 12 referrals from Hurley and 3 from Ascension towards the end of that year. And in 2022, this is our outcomes through July. We have serviced 187 individuals with only 10 refusals. We're really seeing individuals who are experiencing a lot of fear with what is out here. The overdoses, we received data from the opioid surveillance team, and the number of deaths and deaths related to overdose is actually creating a lot of fear and anxiety in the population of people who are still using right now, and they are seeking out services more often. They're looking for more harm reduction mechanisms. They're looking for MAT services. So this is why I believe that our refusals are so low. Is what people are experiencing, seeing their friends and family members dying. So therefore, we have a 94% engagement rate so far this year, which is really great. even though our numbers are lower, they're accessing, they're calling. They call the ORP number now without even going to the hospital, because so many of these clients just have our coaches' direct work phone numbers, and they're able to access them at all times. So Hurley continues to be our, primary referral hospital. 177 of those patients have already engaged in peer recovery coach services. And I don't know why I don't have how many are in the additional services, so that's an error on my part, but many of them have engaged in other levels of care, including MAT. And at this point, I know Hurley has a whole bunch of clients they're ready to transfer to us as soon as our MAT program starts. But at this point, we have been able to continue services for at least 7 of their patients who have started an MOUD. And we, like I was saying earlier, for our funding sources through our PIHP here in Michigan, we are in a PIHP with 4 counties, Genesee County being the largest, and Flint, of course, being the center of our county. Very high rate of overdose rates in our county, even in the surrounding areas of Flint. And we also have partnership with Greater Flint Health Coalition. So we receive funds through MODA, MOP, and Michigan Health Endowment Funds. And then there's just my contact information, but I'm happy to see that Dr. Borjali joined us. I did my best, Doctor. I'm also happy to announce Dr. Borjali is now the new past medical director. So, and continuing his job at Hurley and the many other things that he does. So I'm gonna let you take over.
I don't have a lot else. Can you hear me? I don't have a lot else to add, but yeah, so we're excited to have this, new treatment program. So patients that are coming from the emergency departments or from the hospitals can go right to New Pass and obtain services, and then continue their treatment for opiate use disorder or other substance use disorders right in our clinic, and obtain all of their therapeutic interventions that we need to provide for them. At Hurley, we have a pretty good number of doctors that are ex-waiver, that are getting interested in prescribing Suboxone, over 75% of our doctors. And again, like Erin said, we're the city hospital. We're actually a city-owned hospital. So most of the patients will come to us as opposed to some of the other hospitals, but we're also going to work with those hospitals to, expedite treatment from their emergency departments right to New Pass and get ORP involved as needed. I think that's an exciting new thing that's going to happen in Flint. Social workers really love the ORP connection. It really engages these patients to get their recovery, when they're ready, right? Getting them on board, getting the support they need. I mean, obviously emergency departments can't provide all that support that those patients need. So the ORP is the bridge. They are the link completely to get people into treatment. I don't really have much else to say. Any questions?
Thank you for hearing our presentation.
I have a question. Do you have any way of tracking how the patients do after they have completed their treatment, as to whether they stay away from illicit opioids, or if they go back to using on a regular basis? That is a statistic that seems very difficult to track down.
That is a great question. And that is one of those very difficult statistics that we've struggled for years. I've been in the field for 20 years, and the outcomes for how people are doing, after they've completed treatment programs. The good thing is that our coaches do remain in contact with them for a longer period of time. that our peer coaches track people down no matter where they're at. That's a whole other presentation that I have as well. But, you know, we definitely stay in contact with them. If they are, if they are in new pass treatment program, I definitely have that data because they're here. They may transition into recovery house programming where they can stay here for up to a year and live in a safe and supportive environment. So I definitely would be able to share any information in regards to those who completed our program and then those who stay in contact with their coaches. We run into the dilemma as other treatment facilities may run into. We send out letters, they get returned to sender, you know, phone numbers change, you know, it's a very transient population, but we definitely do our best to seek them out, to find them, meet them where they're at. We have a street outreach team who also makes connections with individuals and helps link them and coordinate them into care. They may resurface again in the hospitals. Like I said, they're very transient. They make their way around Genesee County and some of the other areas around the state of Michigan. But I would love for those statistics to be more definite and to give you a really awesome, successful answer. But, you know, I know there are a lot of people doing well. And the reason why I can say that is we just had a huge hiring of recovery coaches here at New Path. Of people doing well. We have 20 peer recovery coaches on staff. So that I know is already people who have been successful. Some are still in their treatment programs respectfully as they should be as they continue to work on their own stuff. But I mean, for us to be able to hire 20 coaches is down, you know, to me is just a wonderful thing. That just shows the success that is occurring in our community and with people really working towards sobriety and long-term recovery.
Thank you, Aaron and Dominic. That was great. Next, we have Jake Manifel from Henry Ford.
Yep. Thank you, Dr. Rademacher. Can you hear me okay?
I can. Do you know how to take over the control of the screen?
I think I did, but I don't see any buttons. So I'm just going to use my keyboard and see if it works. But thank you for having me. And I am an emergency medicine doc at Henry Ford, Maine, and also addiction medicine board certified. And I'm the director of public health for our emergency department. Let's see, wiggle your mouse to set the view options. I'm not using a mouse. I just have the keypad. So I might just have to have you guys advance for me. Yeah, thanks. So I want to share our experience, and I'm happy to do so. And I'm kind of jealous of of Aaron's program and Dr. Bogiali there. That you guys sound like you have amazing resources, and I feel like ours is much more tied together with Band-Aids compared to yours. But I appreciate hearing how that works, and I'll share how we do things because it seems like it's slightly different everywhere. So this is our experience, if you will. Next slide, please. So we take a kind of a three-pronged approach to opioid use disorder. And I don't know, I missed the first half. I don't know if anyone talked about ALTO programs, also known as alternative to opioids programs, but I view that as our prevention arm for opioid use disorder. And then, of course, with the treatment, our peer recovery coaches and medications for opioid use disorder, but also harm reduction in our naloxone program, which I know many emergency departments now have in place. Next slide, please. And I will not belabor this slide. Everyone's seen it. One anecdotal piece I have, this is probably all driven by fentanyl, and we're taking part in the large study by Gail D'Onofrio from Yale. And I think 80% of our patients with opioid use disorder and withdrawal that are enrolled in our study have fentanyl in it. And then others mentioned, the fentanyl and opioids being found in marijuana, for example, with overdose patients. We're definitely seeing that as well. Next slide, please. So on the prevention arm with ALTO, or alternatives to opioids, short for ALTO, this just a little background. It was put forth by Dr. Rosenberg and Dr. LaPietra out at St. Joseph's in Paterson, New Jersey, and they kind of coined this terminology. And essentially, it's a set of medications which are not opioids for certain diseases, or complaints come in, like back pain, renal colic, headaches, chronic abdominal pain or gastroparesis, and then even fracture and dislocation reductions if you can avoid opiates. There are some modalities to make that occur. Next slide, please. And so the Colorado group, Dr. Stater and his colleagues out there, they actually published this, I think in 2020, but they took these Alto kind of guidelines using subdissociative ketamine, sometimes intranasal ketamine, just using any medication you can think of that's not an opioid to manage these conditions. And they had they put this in place and measured their morphine milliequivalent administered in the ED in the 6 months prior to implementation and the 6 months post-implementation, and showed on the next slide a 36% reduction in across their 10 emergency departments. Annual volumes of this emergency departments were about 130,000 in total. So we sought to do something similar here. Go to the next slide. And we kind of limited to discharge patients. I think a lot of people are dealing with boarding, and certainly at main campus in Detroit, it's ridiculous. I've never seen anything like it in my 15 years of practice. And so we focused our analysis on discharge patients, and we're looking to decrease opioid administration measured in morphine milliequivalents by 15% within the 1 year of implementing our Alto program as compared to the 3-year baseline. And by comparison, we have across our system 450,000 annual visits, so a lot bigger potential target population. Next slide, please. And this is what it looks like. Hopefully this shows up if you don't have your screen in enlarged mode. You might want to do that just to kind of get an idea. We integrated our Alto program into Epic, and it kind of shows you the example medications. And if you look under headache, for example, if there is less than 50% pain relief, then you click that box, and then some steroid and I think valproic acid and magnesium would pop up. Same thing for the chronic abdominal pain after you try your combination therapy, which would be your Toradol and Reglan. Then you're looking at maybe Haldol or subdissociative ketamine. So these are some of the medications at our disposal for extremity and joint dislocation. We don't really use intranasal ketamine yet, although our EMS does, and I have seen patients that come in with that. But I think, the ideal situation would be combining our robust ultrasound division of our emergency department with some of our anesthesiology colleagues and be able to use intranasal ketamine and give that to patients and then set up for an ultrasound guided block. And some of these patients that traditionally we'd be giving Norcos or morphine to right off the bat, we could keep them opioid naive and immobilize their fracture and give significant pain control in that manner. And that's the whole premise behind Alto is, we know about 15% of people are predisposed to opioid addiction, and the less people that are exposed and go home with a prescription potentially is less people to become addicted to opioids. Next slide, please. So just a little bit of the statistics involved here, the outcomes-based research. If you look at this graph, this is the pre-Alto morphine milliequivalent baseline. And so as you can tell, as laws in Michigan started being enacted in 2018 and other things, clinicians becoming more aware of, the major problem that we were seeing from that first graph that we looked at, that I think practice patterns already were kind of trending down over the years, especially starting in 2018. And the big dip that you see in the middle of the screen there is not any legislation. That's actually the national Dilaudid and morphine IV shortage. But as you can see, we bounced back from that and we're able to give more opioids before implementing our Alto program. Next slide. And so this is our data looking about 21 months after the implementation of the program, which was in November of 2019. And we have been trending down. It's not as big of a decrease as we'd like to see, but if you go to the next slide, you can see some of our results in more of a graphic form. So at the main campus, we've been pretty successful. HFH is Henry Ford main campus. We did decrease our opioid administration by about 15%, and across the system, just shy of 10%. And so we have site level data that we can use to, visit places and find best practices like Henry Ford Cottage or Sterling Heights to find out, are clinicians really embracing these medications, or what's going on here, and then share with other sites that aren't doing as well. And I don't know if anyone has any affiliation with the Henry Ford Allegiance, but this kind of makes them look bad by having an increase after Alto implementation. But the reality is we acquired them in 2017 August, so some of the baseline data we didn't have for them, so their trend coming down doesn't look as significant. And then to their credit, they were actually using subdissociative ketamine and lidocaine patches way before we were. So I think the fact that they aren't significantly decreased is more a factor of them being ahead of the curve and employing Alto medications. Next slide, please. So onto the treatment arm, the three-pronged approach, like I mentioned, from the treatment side of things, clearly having X-waiver docs is important. And in January 2020, we only had about 4 of our 50 docs X-waivered. And as of press time, I think there's only 1 or 2 that I need to track down. And as of now, you all know probably it's extremely easy to get the X-waiver. You just have to know your state license number and DEA. So I will literally find the people that aren't X-waivered and sit down next to them and start filling out their form, and then ask them to review and submit it for them. So I just have a few individuals left, but across the board, almost everybody can prescribe, and there'd be almost 0 chance that there are 2 people in the department at the same time and neither of them could prescribe. And so we went live with our program, our MOUD program, in March 2020. We kind of kicked off a lot of the administrative items that many have talked about here, hiring and things like that, and being collaborative with nursing and pharmacy and all the stakeholders about September 2019, but actually went live in March 2020, which coincided directly with COVID. And we probably had maybe 10 or 15 doses of buprenorphine administered in our ED in the previous year prior to March 2020. And as opposed to thereafter, we had about 300 doses administered in the 21 months going forward from there. So significant, I would say, culture change within our department. Next slide, please. And as mentioned, peer recovery coaches, literally could not do this without them. The pictured here with the glasses on his head, that's one of our peer coaches, Stan. He's an amazing guy. The more and more I've gotten involved in this work, I look to him and one of our other coaches, Will, who we've had both since March 2020. And then also we have a new coach, Jim Price. But these guys are amazing. They do amazing work for us. And, the fact that they've been through recovery, I think they obviously have a lot more pull with the patients and add, reality to their situation, because they're functioning at such high levels for us. We are, I think, fairly unique that they are hospital employees at Henry Ford, and a lot of places, at least locally, rely on the local PIHP to set up peer coaching for them. So they are a risk to our program from some perspective, because they are a budget item, although Ariana, I think, mentioned earlier that they are a highly valued piece, and there are many things that we're doing in our department that they support, including our trauma colleagues. In order to be a level 1 trauma center, they need to have a certain number of their patients who are trauma patients have audit Cs performed, and then have interventions for those elevated scores. So there's a lot of ways that these guys have integrated. They go up to the floors, see patients in the ED, they assist with discharge planning. And so I think they're such a valuable piece now that even I keep the penny pinchers away from us. And, I've threatened, some types of bad things if they were ever to be messed with because they're so important to the work that I'm doing personally, but also our program in general. Next slide, please. So the way we do things, it's all integrated into our EMR. And so our nurses, when they see patients in our preliminary area or at some point during their stay, they will do initial screen and ask about substance use. And then if the patient is intoxicated at the time, then they'll hit that first button on the top. It says intoxication. Or if there's a suspected overdose, they'll hit that one. And that will create flags for our peer recovery coaches. And this populates a track board that our peer recovery coaches actually work off of. So we use Epic. Epic track board is the way that we find patients and go see them. And the peer coaches do the same thing. And anyone who receives a flag from either being suspected overdose or intoxicated, or if their audit C scores are greater than 7, or if they answer positively to the drug screening question, whether or not they're using any street drugs or pain medications illicitly. If any of those screen positive, then that creates what you see on the next slide, which is a little column on the track board. So from the provider view, you see a little column titled Expert, and that's how our coaches are kind of known as Expert. We're calling Expert, which is kind of interesting because it's not really what they are, but that's okay as long as they are agreeable to that and we have a flow, then I'm good with that. So for example, if I was seeing patients, you would see 3 of them had red checks, so I know that they screen positive, and then that I may consider calling the peer coaches. But the nice thing is we don't have to call them. This is already populated onto their track board, and while they are working, they will come and see the patients. We have coverage now that we have Jim Price, our third coach. We have coverage 7 days a week, usually 10 hours a day. And then the days that Jim's in, we also have afternoon coverage till I think 10:30 or 11 at night. So there's overlap during the day, but we have a fair amount of coverage. And if I see a patient in the ED and I'm starting them on buprenorphine, our process for after hours is get reliable contact information, and then the coaches call the next day. And that actually, it works more often than it doesn't. And so that's kind of the method that we use. Next slide, please. So in regards to that question that was answered about, does this work? Are these patients staying in treatment? And I agree, it's an extremely difficult thing to answer. But I am interested in patient-centered outcomes, and trying to make the case for these kind of programs to go on after any funding sources would be depleted. And for example, we looked at 31 patients that had a warm handoff, and they had a year prior in our system, or everybody had a year prior, but had a year since the intervention had occurred. And we looked at ED and hospital utilization. And these are patients that had MOUD initiated in the ED and then were handed off to outpatient treatment facilities. We have another cohort of inpatients, but for this analysis, we didn't look at that. And in the 31 patients, 18 of those, so almost 60%, had ED visits either less or had 0 ED visits less than the previous year, or 0 visits. And for hospitalizations, almost 75% of those patients either had 0 hospitalizations or had less than the previous year. So keeping a huge database of every patient we've ever given buprenorphine to, and it's an exhaustive chart review to go through and see, is this somebody that just got maintenance medication, or is this somebody that is somebody that actually was started on MOUD and referred to either inpatient or outpatient. And we track their data using ADT data that's in Epic, so admission, discharge, transfer data, and that will show up at hospitals across the country as long as you give it like the 2-month lag time for it to appear. So next slide, please. And then the last prong, of our efforts is reduction. Obviously our peer coaches are harm reduction. Our peer coaches are involved in that, but we are one of the many hospitals that use in-hand naloxone and have prompts to encourage providers to prescribe not naloxone for at-risk patients, but all opioid use disorder patients as well. And next slide. So just one thing on sustainability. We, like I said, have our coaches as employees, and that kind of limits us financially. I think that the other more common way to do it is to have them be a part of an organization that's funded by those SOR grants. And so I've been talking to MDHHS about why can't we consider our coaches one of those organizations and have them be able to bill Medicaid like they do in those organizations, and that's how they are sustainable. To be honest, completely transparent, I don't understand the finance behind it, but that's something that we are working on. But there is for most insurance plans a dot phrase you can use, and we use this. I think this might add a $100 charge to the bill, and as we know, different insurers pay different percentages of whatever is charged. But this statement encompasses what you need for billing, so it's an opportunity to bring in revenue to help support the program. And I think that's it. And if you can check the next slide. Yep, that's all I have.
Awesome. That was great. Now, a quick question about how, we understand how you kind of incorporated peers. Where do you send your patients and how did you develop that relationship?
Yeah, I'm sorry. Given the title of this presentation, so it's almost 100% peer-based. So when we did hire them, we had a consultant involved that helped pay their salaries for the first year. But then we brought in the local organizations, so Faith, Hope, Love, and Outreach Center. I think Andy mentioned that one. I was looking through the slides earlier. The Detroit Recovery Project. So we kind of had an open house for Stan and Will, who are our remaining leftover coaches, to meet them and then to understand the organizations. And then they are extremely well networked. And honestly, our physicians could not, and I don't know that I could, manage the outpatient landscape without them. And that's why they are so important to us. So literally, I defer 99 to 100% of that to them, including whether or not the patient needs inpatient or outpatient, because they tend to, understand or know, what might work best for the patient. And I totally defer to them. So, but our biggest one, I would say, is FHLOC, but Detroit Recovery Program, Team Wellness, and some are dictated by the patient's insurance and their county of residence and things like that. But I guess the bottom line is we as providers are so removed from that it makes it easy. And that's typically what you want when it was a program like that is, you've made it easy on the docs. We take care of the medicine part, and then our peer coaches navigate the outpatient landscape.
Awesome. So quick summary of all the programs. So at DMC, in Andy's program, they have peer recovery coaches through DWIN, and they help facilitate outpatient follow-up. Ariana through California Bridge, they have their peer recovery coaches that are funded basically by their grants that are from the state. And then in Flint, the peer recovery coaches are housed by New Paths, which is state funded as well, but not directly affiliated with the hospitals. And then Jake has a model in which the hospital Henry Ford has hired the peer recovery coaches directly. So I think you can see that there are multiple ways to do this. I think we're all hoping that in the future it's easier, that they can directly bill, and then it makes it easier for hospitals to finance it. But as it stands, there are a variety of ways to do this. And I think today you were presented with a couple different options to proceed for your program. Does anyone have any questions? All right. Well, thank you all very much for your time today. It was really nice to hear about what's going on across the state and across the country.